So I'll introduce the next speaker. Dr. Gadhia is a vascular neurologist who directs the Acute Teleneurology and Telestroke program at Houston Methodist. He did a fellowship at the Massachusetts General Hospital and came back to us, thankfully coming back to us, and didn't stay there. He also serves as the program director for the Stroke Fellowship and associate program director of the Core Neurology Residency Program. His interests include novel neuroimaging techniques, teleneurology, telemedicine, concussion, and cryptogenic stroke evaluations, and he'll be talking to us on replacing the time window for all acute therapy.
Thank you, Dr. Klesnik, for that introduction. So it was interesting to hear a little bit about what you guys are doing with music recovery and different neurological models. And maybe we'll shift gears a little bit to talk about the acute stroke therapy and maybe using some of these novel imaging techniques for acute stroke triage. So I have no relevant disclosures. I'm going to give a little outline. We're going to start off by defining what a last known normal or last known well is and give some case examples of why our talk today is really relevant. I'm going to go through a timeline of some of the acute stroke studies and the current stroke care in 2021 now, some of the advances in imaging and the automated softwares that are available, what the future of stroke triage and really probably what it should look like now, and then some of the clinical trials and future directions we should take. So what is the last known normal? It's really defined as the last time a patient was known to be without the current presentation of acute focal neurologic deficits, which are concerning for the stroke presentation. It really is not the time that the symptoms are first discovered, unless in the unique circumstances we'll see it's an acute witnessed onset. And so I'm going to give a couple of case examples of why this is relevant. So the first case, a patient who went to bed normal at 9 p.m. and awoke the next morning at 5 a.m. with right-sided weakness. So the symptom discovery is 5 a.m. With the right-sided weakness, but the true last known normal is 9 p.m. Now this is where the discovery portion, the detectiveness of the vascular neurologist is very important, because this is where we need to probe the patient or maybe a sleep partner as to whether they got up in the middle of the night, was there a use of going to the restroom or something like that, where we can maybe shorten that time window. But I'm going to try to paint the picture of why maybe we can use symptom discovery and a marker or biomarker through imaging for symptom onset. The second case is a patient who was at work making copies and had an acute onset of right-sided arm and leg weakness. This was a witnessed onset at 12:15 p.m. So this is that unique circumstance that I talked about, where the last known normal is actually the time of witnessed onset of symptoms at 12:15 p.m. And then the third case, and this is the one that bothers us and keeps us up at night, is the elderly woman who lives alone at home, really has no family, keeps to herself most of the time, and she was found on the floor by her concerned neighbor at 4:15 p.m. She had a left gaze deviation, she had some right-sided weakness, and unfortunately the last known normal that we've got, the last time that the neighbor saw the patient was at 9 a.m. 5 days prior to that. And so really the last known normal, unfortunately, would be 5 days prior to her presentation. And those of us in stroke care and in vascular neurology know that this patient probably wouldn't meet criteria for any acute treatments, whether it's TP or thrombectomy. So I ask you all the question. Unfortunately, we can't be as interactive as we want to be in person, but what did all three of these patients have in common? And on the left side, you'll see that there's an axial image of a non-contrast head CT. And for those that are astute in looking at some of these images, you'll see a hyperdense left middle cerebral artery vessel. You really don't see any hemorrhaging there. The patient had what we call an aspect score of 9 to 10 across all three examples. And on the right there, you'll see the CT angiogram for this patient, and that arrow really marks where the cutoff of the left middle cerebral artery in the M1 trunk really is. This is a large vessel occlusion stroke syndrome. And for those of you that may have not seen one of these printouts, this is a rapid printout, just one of the many automated imaging software tools out there of a CT perfusion. Again, all three patients had this in common, which is essentially that on the left side you see that there is no core, that there is no established stroke injury of the brain that we can see based on a CT perfusion that's defined by the cerebral blood flow of less than 30%. And on the right there, you can see green. We sometimes say green means go. This is the amount of tissue that we have the potential to save. It's penumbra or salvageable tissue. And you can see that the volume of that tissue is 165 cc's. That means that we have significant opportunity to potentially prevent further progression of really any infarct there. And Dr. Klesnik minimizes what he does, but as the plumber, this is really where we require a lot of that assistance to help save that patient from disability and really even death. So I'm going to ask you the other question, the other flip side of the coin. If we got this image now, or this printout of the patient, how would this change your management? And it's essentially showing that the pink or the red there on the left-hand side is that there is really no mismatch, that the infarct has already progressed to the point of causing essentially irreversible damage to the brain, and you really don't have very much in terms of salvageable tissue that you see on the right. And so this is one of my favorite slides. I use it in virtually every talk that I give because I think it gives you an idea chronologically as to how far we have come in the era of stroke. And you can see that we'll start back 25 years ago or so in December of 1995 when we had a landmark NINDS or the NINDS TPA study for the first time showing an acute therapy for ischemic stroke, and this was with Alteplase, showing the benefit of giving TPA in patients with the last known normal of within 3 hours. And so this really changed the landscape of acute stroke care, from really essentially following a patient and seeing them complete their stroke syndrome and working with them from the therapies and secondary stroke prevention, but this was the first truly acute therapy that we had. And you can see that this timeline really shows that it took almost 13 years before we had the next landmark study that really changed management of acute stroke patients. And it was in 2008, 13 years later, with the ECAS-3 study published by our European and Australian colleagues, really expanding that time window out to 4.5 hours now. And why did it take so long for us to really get to the point of advancing our stroke field? And it was because there was hesitancy. It was a new medication, it was a new treatment, and the concern was a powerful blood thinning, a lytic agent, and the concern was, what are we going to do with these patients if they have a complication? Even though there was obviously a benefit that outweighed the risks of bleeding, what are we going to do with these patients when you're out in the community and you've got a hemorrhagic transformation and you don't have a neurosurgeon close by? And so there was a lot of hesitancy in its use, even amongst the neurology community, and it took a while, it took over a decade to really get comfortable with its use. And you can see there that in 2013 up until 2015 that we now shifted gears into, well, what are we going to do with the most severe of the acute stroke syndromes? These are the ones where you've got a large vessel occlusion, the most disabling of the strokes, where we know that TPA is helpful, but in about 70 to 80% of these patients that you need something else, that these patients are still left with some disability. And anecdotally, we knew that there were some patients that were going to benefit from removing that clot, that at least looking at the patient and looking at the blood vessels, that removing that clot was going to lead to some benefit. And unfortunately, what we can learn from this timeline slide is that it's a matter of time before you'll find the right exclusion and inclusion criteria for patients, that you will find benefit in the appropriate patient population with essentially any good therapy that you study. And in 2015, we had the landmark Mr. Clean study that showed the benefit of endovascular thrombectomy within 6 hours of the last known well. We went even further. We had a number of other studies published in the following year, and all of these were presented at the International Stroke Conference, essentially showing and confirming the benefit of endovascular thrombectomy, this large vessel occlusion procedures within 6 hours of last known well. And I like this timeline slide because, once again, it shows you how much more narrower we get within the time window to really advance science and expand the time window. And you can see that just the following year and the year after that, in 2017 and 2018, we had 2 landmark studies that expanded that time window from 6 hours for thrombectomy out to 24 hours for thrombectomy. So you can imagine that there is a significantly larger number of patients, all these wake-up patients, these extended window patients, that are now able to be triaged for acute therapy. And for the first time ever at the International Stroke Conference in 2018, there was a revelation of this data. It was published, the initial results. The paper was made available through the New England Journal of Medicine about 10 minutes later. And 10 minutes later, the acute stroke guidelines were published and made available through the American Heart Association, American Stroke Association. First time ever, really, for something like that to really happen. That was really a landmark event. And now we've gone full circle. We've gone back to lytics. Well, we know that thrombectomy is available at thrombectomy-capable centers, comprehensive stroke centers, and we'll hear a little bit more about that later on in the day. But we've gone full circle to what is available at essentially every one of the sites, and with the use of technology like telestroke and having an expert at the bedside, we can offer some of these intravenous agents by triaging patients very rapidly and appropriately. And so in 2018, 2019, you can see there were 2 studies that we'll talk a little bit more about, the Wake Up and the Extend study, going full circle looking at intravenous lytic agents, these 2 with TPA, but other studies going on with tenecteplase or TNK as well, and really now showing that advanced imaging can be used as a triage agent. So a little snapshot as to what our world looked like for about 20 years. On the left, the acute stroke workflow was patient presents. If they're within 4.5 hours and they don't have a bleed on the CT scan, you either give them TPA or you don't. If they don't meet criteria because they're more than 4.5 hours from last known well, you admit them and you do all the other things for stroke evaluation and secondary stroke prevention. And you can see there on the right that, and Dr. Klesnik knows this because he sits on our committee of the Acute Stroke Task Force, that it always says draft because we are constantly always tweaking our protocols and our guidelines to try to advance and really stay ahead of the science. A lot of this work that we are doing to try to see which patients will meet criteria, how can we get patients to meet criteria and have potential benefit from these very powerful acute stroke therapies. And so you can see there that is a changing graph for us all the way throughout every one of our meetings. So I want to touch a little bit on the modified Rankin Scale score. This is our functional disability outcome score tool that really in the stroke world we use with essentially every study. We typically look at 90-day outcomes, but these are done at a premorbid state when a patient comes in. It's done at time of discharge, and it's also done again and follow-up at 90 days. And we have the benefit of having a robust research team within our stroke group who will essentially get a modified Rankin Scale score on every one of our patients at 90 days through a phone call with 96% or so success. And it's a scoring tool going from 0 to 6. Obviously, the lower the scale or the score, the lower the disability. 6, obviously, the worst outcome, which is death. And this is that timeline slide essentially showing you this, the exact same thing graphically, showing you that there's a leftward shift towards the modified Rankin Scale score in all the treatment groups when compared to the placebo. That you can see that with TPA, with endovascular, and so on and so forth. So really reducing disability and reducing mortality. So why does all this matter? Why is what I'm telling you over the next 10 to 15 minutes, why does it matter? Well, this last known normal has served as the cardinal value that dictates acute stroke care, right? And we know that history, having done this for almost a decade now, in many ways, shapes, and forms, that the last known normal can be different, and it's incorrect over 50% of the time because you can modify that last known normal with more history that you get, and unfortunately you're working against a running time clock for the patient. And so we need to find some better way to triage these patients. It has determined eligibility for TPA, it's determined eligibility for thrombectomy up until now, and more importantly, as I've just showed you, it determines outcomes, and that outcome is the most important outcome, which is the disability outcome. And many would argue that we really need some sort of biomarker, whether it's imaging, blood, or what have you, a measure of symptom onset that's going to serve more of a role in determining acute stroke therapies. So here are those two papers, those landmark New England Journal of Medicine papers with the Dawn and Diffuse study for thrombectomy, and the same for the extended window lytic agents, the Wake Up study, as well as the Extend study. And here's the 2018 excerpt from the American Heart Association showing the benefit of the two extended window thrombectomy studies. And you can see that a good outcome, that modified Rankin Scale score of 2 or less, that's slight disability or no disability, in those patients who receive treatment, 49% versus 13%. And in the Diffuse 3 study, a similar study with a little different inclusion-exclusion criteria, same thing, 45% versus 17%. And these are very powerfully powered studies showing really that you only need to treat a couple of patients to see benefit in these very aggressive therapies. So here were the 2018 AHA-ASA guidelines with a level 1 recommendation for really offering extended window thrombectomy and screening these patients, whether it's CT perfusion, DWI-MR perfusion, or clinical radiological mismatch, what have you, with the patients. And so I used to title this slide The Future. It really is the now. And according to a multitude of these recent TPA and thrombectomy, and I'll replace TPA with really any lytic agents because we're studying a number of novel agents as well, that the ability to provide these acute therapies both within the window and in the extended window can mean the difference between functional dependence versus functional independence. And this arbitrary value carries significant weight. It determines pathways for treatment, and it needs to be correlated. It's being correlated with imaging characteristics such as perfusion imaging, CT, and MRI. And so here were the 2019 updates. This is with the published wake-up study of the extended window lytic agents. These are the intravenous lytic agents. And you'll see a little bit of a discrepancy because they're, and I'll show on the coming slides that there's an asterisk next to some of my points because there are some flaws, there are some things that can be improved upon with the studies, but I think the gist of the information is that there is some benefit, that there are patients that will, that a traditional time window really doesn't fit, and that there are patients that we can still help in the extended time window. And you'll see there with point number 5 that there's a level 1A recommendation to really be screening these patients with advanced imaging. And here's the discrepancy that I was talking about with the level 2B recommendation, because many of these studies, just to their unfortunate circumstance, were being conducted at the time of other studies like the Dawn and Diffuse study, where many of these patients, after it being published, were no longer to meet criteria for being enrolled in the study. And so the studies were stopped early, and for that reason they weren't powered as appropriately as they should have been. So what does acute stroke care and triage really look like right now? So initial assessments, we've been used to non-contrast CT. It was a paradigm shift about 5 or 7 years ago when we added CT angiography to every patient for acute stroke evaluation. And now we will likely be shifting to using advanced imaging studies like MR and CT perfusion. And these perfusion studies can help to define the extent of ischemic injuries, allows for assessment of that core and the penumbra, which I showed you with that printout. So inclusion of patients who are these wake-up or unclear times of onset, there's sort of that asterisk because there were, as I told you, some inclusion-exclusion issues with patients with the studies that have been published, but there are studies still ongoing which will likely narrow in and hone in on those patients that are most likely to benefit. And so those patients that are more than 4.5 hours from a last known normal, don't really have a large vessel occlusion but have no real evidence of injury, probably should get some hyperacute imaging with perfusion studies or stat MRI in consideration for extended window lytic therapy. CT brain or MR perfusion is only really required to determine eligibility. You only want to opt in patients when you absolutely need it. You really shouldn't be using precious time in those patients where you've got the history and you know the information that you have to make your acute decision making. And so those patients that are coming in within a 6-hour time window, for example, really don't need the advanced imaging, which can take 10 to 15 minutes in some instances because time is brain. And as we know that you're losing about 2 million brain cells every minute that you wait and not reperfusing the brain. With some of these automated softwares, Rapid and VisaI are just two of those examples that I'll give. You can have this information within minutes. They've got sort of their own paradigms and their own protocols that you can get these through an email or through an app format really very rapidly. And in the case of extended window large vessel occlusions, that the going mantra is that you really should be doing this as close to the time of groin puncture as possible. What we have seen, and even through our work group, is that transfer times have improved. The longer you do something, the more you refine processes, transfer times continue to improve. And so now is the time to start thinking of should be triaging some of these patients at the sites before they leave, to ensure that, number one, we're not utilizing resources that don't need to be used for patients that probably won't have benefit at the Comprehensive Stroke Center, but more importantly, to triage and opt in those patients who would meet criteria that otherwise could be missed. Once again, using that perfusion imaging has some other use case scenarios. So if you've got a large clinical suspicion for a large vessel occlusion, clinically, you see a patient, they meet these criteria with cortical signs or have high night stroke scales. We know that there are a good number of vessel anomalies like trifurcations of the middle cerebral artery, for example, that you may not catch on a CT angiogram, and that study may falsely clue you out of this being a thrombectomy patient. And if you've got a high clinical suspicion, there really is nothing that overrules your clinical diagnosis and your clinical suspicion. That in those cases, a perfusion image may help show a mismatch, or those patients may be taken to an angiogram suite to define the vessels. It can help distinguish between stroke mimics such as seizures and conversion disorder. Oftentimes you may see the opposite perfusion maps in patients who are having seizures with increased perfusion. And then once again in the extended window lytics, as we talked about. So here's what the rapid printout looks like. I showed you this early on, that they use a core definition of a cerebral blood flow of less than 30% and a penumbra map of Tmax of 6-second delay. The Oleosphere is another one, was used in the Thrace study, is also fully automated and rapid outputs, and the VisaI obviously is another one. It also has the auto elbow detection, as does the other softwares now as well. They all have apps available as well. And so what's now in the future? What's the research pipeline really look like? And I think that one thing that I feel confident saying is that the advanced imaging, these perfusion imagings and other novel sequences for patient selection in clinical trials will probably play a large role in studies going forward. If you want to hone in on that patient population that's going to be the most of benefit, why not use all the data that you can get to include those patients and exclude those that wouldn't likely have improvement with the acute therapies. This is not only with thrombolytics and endovascular studies where we're going to be looking at novel agents and novel devices and expanding the window, but also cell-based therapies, things where we look at targeting neuroinflammation like multi-stem COBIS or ongoing studies that we've got here, but looking at Tregs and different modes of delivery, whether it's IV and IA, and more importantly for defining the time window of when we should be giving these therapies. So the future directions, I'll end here with looking at the likelihood of imaging-based biomarkers for patient selection. And really, I hope to see that there's no real ceiling for a last known normal, that we use that as a surrogate measure. If we have it, we'll go by it. And if a patient meets criteria, we'll use it. But if they don't, we really should have that curiosity and really the drive to find those patients that will additionally meet criteria and additionally have benefit with acute therapies. And we'll probably see these in the guidelines. Same thing with the AI projected role of triage of stroke patients and the automated imaging review, which we have already got, but also, as Dr. Volpe and Dr. Wong have looked at, is the AI for the clinical exams, and including patients with larger infarcts and potentially lower clinical deficits. But how are we going to triage these cares? And we're going to have some aspect of an expansion of the virtual care environment to do this. And so I'll end there with some references and leave it up for some questions. So thank you for having me.